Thank you, Dr. Smeltzer, and thank you, Villanova, for having me today. I'm here to talk about a topic that's very near and dear to my heart, which is organ transplantation. Specifically, I want to talk about barriers to kidney transplantation in the U.S. I conducted a literature review to explore this topic, and I found that barriers to receiving an organ transplant, specifically a kidney transplant, exist at the patient level, the family and social network level, the healthcare system level, and the community and cultural level. So I wanted to find out what these factors were, or what these barriers were. So what we're going to do today is we're going to talk about the problem. So why is access to kidney transplantation an issue in the U.S.? And then I want to talk about how I conducted my literature review. We'll talk about what I discovered, and then we'll end with a conclusion. So access to kidney transplantation is an issue because there's an organ shortage in the U.S. So not everyone who needs an organ will get one. Currently, there are over 100,000 people on the U.S. kidney transplant waiting list, and candidates will wait an average of 5 years for a transplant and sometimes longer. A lot of people will die before ever receiving a transplant. In 2016, over 4,000 people died on the waiting list. And these deaths could have probably been prevented if there were enough organs available for transplantation. But there aren't, so the transplant community is challenged with finding a way to fairly distribute the organs that we do have available. But we haven't figured out the perfect way yet. And we know this because significant disparities exist in access to kidney transplantation. So I want to focus on barriers to receiving a transplant among waitlisted candidates. It's not just a matter of getting waitlisted, waiting your turn in line, and hoping that an organ becomes available that matches. There are actually factors that increase or decrease your chance of actually receiving a transplant, and I wanted to find out what those factors were. So I used the social ecological transplant model as a guide, and I wanted to, like I said, identify what factors at the patient, family, and social network level, healthcare system, and community cultural levels increase or decrease a patient's chance of actually receiving a transplant. So I searched the literature, and I did have some inclusion criteria. I only included quantitative studies versus qualitative studies. I included studies that were conducted in the US because I was interested in access to kidney transplant in the US. And I only included studies that focused on kidney transplant versus other types of transplant and adult transplant. I searched PubMed, CINAHL, and Google Scholar, and after applying the inclusion criteria, I found 19 studies. Of the 19 studies, most were secondary data analysis. About half were retrospective and half were prospective. The year of publication ranged from 1995 to 2015, with a majority of the studies conducted within the last 10 years. I found 8 studies that explored how patient-level factors influenced access to transplant. Only 1 study that explored family and social network factors, 4 articles that explored healthcare system-level factors, and 6 articles that explored cultural-level factors. So the patient-level factors that I found were age, education level and health literacy, employment status, body mass index, and substance abuse. So we'll talk a little bit more about these. So age. There is no cutoff age limit for a kidney transplantation. Every case is evaluated separately. Today, 66% of the population on the kidney transplant waiting list is over the age of 50 years old, and almost 1/4 is over 65 years old. And I found 2 studies that examined how older candidates fared in regards to access to transplant. What I discovered was there has been an increase in the number of older adults listed for transplant over the last few years, but a decrease in actually receiving a transplant after they were waitlisted. The researchers of the study number 1 that I found reported that older patients were waiting longer for a transplant than prior years, and almost half of the candidates over 60 years old were projected to die within 5 years before receiving a deceased donor transplant. And this percent was even higher for patients who were 70 years older, who had diabetes, and were white. The researchers in study number 2 also reported that access to transplant for older candidates ages 60 to 75 years old worsened over time. These 2 studies were conducted in 2006 and 2007. But it's important to note that in December of 2014, a new kidney allocation system was implemented. The primary goal of this new system is to maximize the life of the transplanted kidney. So therefore, the best kidneys go to the candidates projected to live the longest. And results from a preliminary study suggest that younger adults ages 18 to 50 are benefiting from the new system, and older adults are at a disadvantage. The transplantation rate declined by 7% for those between the ages of 51 and 60, by 10% for those between 61 and 70, and by 24% for those older than 70 years old. So clearly, age and access to transplant is still an issue that we need to address through research. Education level and health literacy. So I only found one study that explored education level as a determinant of access to transplant. In this study, college graduates were 3 times more likely to get transplanted after waitlisting compared with patients without a high school degree. Another study explored health literacy and found that higher health literacy was a positive and significant predictor of getting a transplant. And I think these findings indicate that we need to think about how we promote organ donation and transplantation and how we deliver educational material to potential transplant candidates and potential donors, living donors. Because I don't think that people who lack a college degree have an aversion to organ donation and transplantation. I think that we as a society just aren't meeting their needs, their educational needs. And I foresee nurses picking up the slack because we have the ability to connect with patients and to really tailor to their specific needs. So employment status. Researchers noted that employment status could potentially be considered a marker of overall physical and mental health of an individual, reflecting health consciousness and possibly greater likelihood of following health advice. A study was conducted to evaluate the relationship between employment status and access to transplant, and the researchers reported a relationship between how much a patient worked and access to transplant. So patients who worked full-time, part-time, or were retired or disabled were more likely to get transplanted after being placed on the waiting list than patients who were unemployed. And you may be wondering why employment status has anything to do with transplant. Well, the biggest concern with unemployment is the ability or inability to pay for transplant medications. So initially after transplant, medications are covered by Medicare for 36 months. After that time, it's expected that the transplant recipient will rejoin the workforce and they'll gain medical coverage to cover their immunosuppressive medications. So you can imagine if you were unemployed, how hard that might be to go on and get a job after you get a transplant. And transplant medications can cost anywhere up to $17,000 annually. So you can imagine that's expensive for anyone to pay, but if you don't have a job and you don't have medical care coverage, how are you going to pay for those medications to keep your kidney working? Body mass index. So in previous kidney transplant research, it was discovered that overweight or obese patients were at an increased risk for adverse post-transplant outcomes, including delayed graft function and rejection. There is no specified BMI cutoff for kidney transplantation. Every center is different. Most centers use 35 as their BMI cutoff point. I've included 2 studies here that examine the relationship between BMI and waiting time for a kidney transplantation. Study number 1 found that median time to kidney transplantation increased as category of BMI increased. So higher BMI was associated with lower likelihood of receiving a kidney transplant. Study number 2 was interesting. Women with a BMI greater than 25 were less likely to receive a transplant than women with a normal BMI between 18 and 25. Whereas for men, BMI greater than 35 was associated with a decreased likelihood of receiving a transplant. And actually, men with a BMI between 25 and 35 were more likely to get transplanted than men with a normal BMI. So with the obesity epidemic, that the U.S. currently faces, I think it's important to determine how either to A, safely transplant patients with a higher BMI, or B, come up with a way to help patients lose weight prior to transplant and help them keep that weight off after transplant, which is difficult because they're on high doses of steroids, which we all know can cause weight gain. Substance abuse. So the researchers reported that previous studies found a relationship between substance abuse and inferior renal transplant outcomes. However, it was unclear how substance abuse is related to access to transplant. So I found one study that reported patients with end-stage renal disease abusing or dependent on tobacco, alcohol, or illicit drugs were less likely to be placed on the waiting list for transplant, and once on the list, less likely to be transplanted. And polysubstance abuse was associated with either further reduction in likelihood of receiving a transplant. Now, family and social network factors. So social support is one of the factors considered during the pre-transplant evaluation. The patient's social support system, whether it be friends or family, is integral to the transplant patient's success. I found it interesting that I only found one study that examined the role of the family or social support system in access to transplant. the researchers reported that waitlisted candidates who were married were more likely to receive a kidney transplant than candidates who were never married or widowed. If we're going to consider social support as a factor assessed during the pre-transplant workup period, then we need to examine how this factor affects access to transplant. One study is not enough, and this is clearly a gap in knowledge that we need more research on. Healthcare system factors. So under Medicare, there are 18 end-stage renal disease networks that service geographic areas based on the number of end-stage renal disease patients in that area. And then within each end-stage renal disease network, there are dialysis facilities that are responsible for providing pre-transplant care to patients. And it's been noted that variability in transplantation rates between dialysis units, but we don't know why. So researchers conducted a study to examine what dialysis facility factors were associated with low transplant rates or high transplant rates. And this study found that dialysis facilities that were for-profit status, facilities with a higher percentage of Black patients, patients with no health insurance, and patients with diabetes had lower transplant rates among their patients. Dialysis facilities with a greater number of facility staff in an area with more transplant centers per 10,000 end-stage renal disease patients and had a higher percentage of patients who were employed or used peritoneal dialysis had higher transplant rates. More research is needed to determine if these factors are modifiable. If we maximize factors related to high transplant rates, like increasing staffing at dialysis units, could this help increase transplant rates among dialysis facilities known to have lower transplant rates? So then I wanted to look at what geographic differences exist in regards to access to transplant. Well, there are state-to-state differences. Some states are transplanting as high as 150% above the national average transplant rate, and those states are Iowa, Maine, Pennsylvania, Rhode Island, South Dakota, and Wisconsin. And then there are states with transplant rates 60% lower than the national average: Arizona, Connecticut, Hawaii, Mississippi, and North Carolina. So what state you live in could affect how long you wait for a transplant. DSAs are donor service areas, and in the US, 12 UNOS regions, and there are 1 to 5 donor service areas in each region. There are about 58 donor service areas total in the US. Organs are first allocated within a DSA, and if there's not a match, then they're allocated to the region. And this study showed a growing and worsening geographic disparities between DSAs over time. Some have an average waiting time of 1 year, while others have an average waiting time of 4 years. So in other words, where you get dialysis plays a role in how long you wait for a kidney, and this shouldn't be a factor. In another study, researchers reported that waitlisted candidates who lived farthest from the transplant center were less likely to receive a deceased donor transplant compared with candidates who lived closer to the transplant center. Clearly, geographic disparities exist, despite the implementation of the final rule in 2000 that mandated geographic equality in organ allocation. Where you live, what state you live in, where you go to dialysis should not play a role in how fast you get a transplant or whether you even get a transplant. And lastly, racial disparities in healthcare exist. Racial disparities exist in access to kidney transplant and have been documented since the 1990s. I found 4 studies, and in each of them, white patients were more likely than Black patients, Asians, Native Americans, and Hispanics to receive a transplant. A major change under the new kidney allocation system was to give more weight to time spent on dialysis rather than time spent on the waiting list. This change was largely meant to increase transplant access to minorities who are not often placed on the waiting list in a timely manner after beginning dialysis. So we need more research to determine whether this change had any impact on increasing access to transplant for minorities. These studies I presented to you support the idea that access to transplant is influenced by multiple factors at various levels within the social ecological transplant model. And this idea that factors within multiple systems influence transplant led me to question what factors influence the topic of my dissertation research, which is travel for transplant and transplant tourism. Travel for transplant is when people seek transplant outside of the US. They leave the US for some reason. And I'm wondering, are people with factors identified as barriers to transplant in the US, like older candidates or unemployed, or people with higher BMIs, more likely to travel abroad for transplant? In other words, because they have a difficult time getting a transplant in the US, are they more likely to go abroad? So my dissertation research will explore factors related to travel for transplant among patients removed from the US waiting list. I'm gonna look at sociodemographic, socioeconomic status, functional status, and body mass index. So stay tuned, that should be in a year, hopefully.
Thank you very much. That was very interesting. Let me ask if there are any questions that anybody has for Brittany.
Oh, great.
One in the back.
I didn't look at that, but that.
Repeat the question if you can.
I think your question was, did you look at donor rates within an area for geographic issues? And that is one of the issues. There are areas where they have high donation rates and low transplant needs, and vice versa. So you've all probably heard Steve Jobs, who got a transplant very quickly, and he traveled. He lived in California, but he went to Tennessee because they had high amount of organs to be able to be transplanted, but not so much of a need. So he could get one quicker. But I didn't look at that in this, no.
Okay, I guess not. Thank you so much.